The broadcast is now starting. All attendees are in listen-only mode.
This is Danny Bobrow, President of AIM Dental Marketing, welcoming you to this installment of the Practice Perfection web-based education series. Today's presentation is entitled, Simple Steps to Optimal Oral Systemic Patient Management. It's all about hygiene. Patti DeMatteis, ASDH, RDH, and Lora Boukheir, BSDH, RDH, EFDA, are founding members of the American Academy for Oral Systemic Health and preceptors of the Bale-Donin method for heart attack and stroke prevention. In this most enlightening presentation, Patti and Lora introduced the DHE method. The instructors introduce the 14 steps to effective patient management. As leading hygienists and managing partners, along with Drs. Barb McClatchy, DDS, and Eric Goulder, MD, of the Heart Attack and Stroke Prevention Center of Central Ohio, they demonstrate how to integrate the oral systemic practice model into clinical practice. Patti and Lora will discuss the important role of the hygienist and how creating consistent treatment protocols delivers outstanding patient outcomes. This program will demonstrate how practicing the DHE method decreases no-shows and cancellations, increases periodontal services, and sells more dentistry. Before we get to today's special presentation and equally special presenters, I want you to know that Practice Perfection webcasts are approximately 90 minutes in length. While attendees are in listen-only mode, we invite you at any time to submit your questions or comments using the question button on your screen. We will allow time following the presentation to get your questions answered. If we do not get to your question during the webcast, Lora and Patti have promised they will answer them directly following the webcast. I should say, not to overpromise, as soon after the webcast as practical. Now, those who view this presentation may apply to receive 1.5 hours of continuing education credit as approved by the Academy of General Dentistry's PACE program. Shortly following the webcast, you will receive instructions on how to receive your CE. Participants are cautioned about the dangers of incorporating techniques and procedures into their practices if the course has not provided them with adequate clinical experience to allow them to perform it competently. And now, it is my pleasure to welcome my friends, Patti DeMatteis and Lora Boukheir, to the Practice Perfection stage. Hello, friends.
Hi, Danny.
Hi.
Lora and I are here, and we are so excited to be on this call tonight. We want to thank all of our colleagues for listening in, as well as AIM Dental Marketing, for the opportunity to share our method our 14-step method to effective patient management and transitioning to oral systemic practice. Unfortunately, everybody's not on board yet. So what we know is that 90% of clinicians are still thinking more about teeth than the host or the patient and what inflammation really means, and still diagnosing based on signs and symptoms, pocket depths, bleeding points, all subjective data. I graduated in 1972 from Western Kentucky University, and I have completely enjoyed my career as a hygienist. My life revolves around my family, golf, soccer, and football. To make a difference in dentistry, I started DHE while living in Arizona in 1996 and moved back to Ohio in 2002 when Lora joined me as a co-owner of Dental Hygiene Excellence. Lora and I both live in Dublin, and Lora, like me, is very passionate about her family and about the advancement of dental hygiene. Together, we have defined our passion as the oral systemic movement, and our purpose is to help others, starting with ourselves, our family, our patients, our colleagues, and even our community. And our mission is to make a huge difference in dentistry. The oral systemic connection has come out as fast, yet those of you and I myself have been clinicians for a long time know that through the years we've treated patients with standard care and knew that they didn't respond as well as we thought they should and really didn't understand why. 20 years ago, I had a patient named John who was an uncontrolled diabetic. He had moderate active periodontal disease, and we treated him non-surgically, and 3 months later, his diabetes was remarkably improved. His physician was confused. He was confused. I was sort of confused. It was like we didn't realize. We knew something with having gotten his periodontal infection under control had something to do with his diabetes. And now what we know is that there is research emerging every day that lets us know that, yes, there is a systemic connection that supports our suspicions about something else was going on. And what we even know now is that patients that are treated for their periodontal infection actually can lower their A1C a full point. That's better than even medication can do. So we must collaborate with the medical team to get a better outcome for all of our patients. These are some of the professionals that we just like to acknowledge that we've learned from, and they're out there trying to make a difference as well and really promoting the oral systemic movement. We just wanted to acknowledge those people. Lora and I are so thankful that we got the memo about the first AISH session in 2011, and we became founding members that year, and we haven't missed a session since. We're looking really forward to a couple of weeks from now attending the 6th annual session of the AISH group, and it's September 15th through 17th. At the same first session, we were lucky enough to meet Dr. Vale and Dr. Doneen, and then we also attended their Vale-Doneen preceptorship course. We've taken what we've learned from these leaders in the oral systemic movement and implemented it into patient care in our own practices and also in our clients' practices. As of July 2017, we are so excited that we'll have an even wider opportunity to practice what we've learned from all these special people in the brand new Heart Attack and Stroke Prevention Center of Central Ohio with Dr. McClatchy and Dr. Goulder. Practicing the simple steps, Danny, the simple steps, the 14 simple steps, what we find is we find solutions to practice management issues. The results definitely are decrease in cancellation and no-shows, increased periodontal services, and more dentistry is sold. As practicing clinicians, Lora and I know that the 14 steps are simple, but the process is not always easy. It takes a team to execute the 14 steps with every patient. But following the DHE method ensures that your basics are in place so that you can actually move on and transition to an oral systemic practice. And your patients will be provided comprehensive care and an excellent patient experience. Each team member in the 14 steps has a primary responsibility for one or more of the steps. So we actually practice with our teams, and we do this ball toss, and each team member who is primarily responsible for the steps plays the game. So the way it works is the person who is responsible for step 1 starts the toss. They name the step and toss the ball to the team member primarily responsible for step 2, and so on, all the way through all the 14 steps. If anyone drops the ball, they have to start over, and they hate it. Unfortunately, in real patient care, we don't get that opportunity for a do-over. If we drop the ball with our patients, then the patient experience goes south, and we could even lose the patient.
Well, good evening, everyone. This is Lora Boukheir, and I hope that you can see that we are all about hands-on, as you can see from Patti in that last exercise. That's really what makes us unique. We provide the 3 C's. That's chairside clinical coaching. We're all about hands-on implementation, one-on-one plus group coaching, and we continually practice with our teams through role play, just as you saw on the previous slide. And so one of the key components is that we're creating proven protocols from clinical application, and this is huge for us. We do have a release form for media. This is from a patient that you will be seeing some actual charting from, and so just want to disclose that and allow you to see that he did give consent for that information. So the question at hand, and more importantly, is how do you possibly integrate the oral systemic practice model into your clinical practice right now? We know in time of chaos, we learn things, and then we go right back to what we call dental insanity. Every day we try to make a difference, but if we actually don't change a few key elements, we end up kind of falling back into those old habits. So tonight we want to share those key elements with you and help you make that first step. And so really the first key element is all about mindset, really switching that mindset tonight from what we call calculus, stain removal as a hygienist, to really about bacterial burden and the host. Secondly, how important is morning huddle? We're going to capture this and talk about this in depth and hopefully have some fun around that, as well as then what are the clinical testing protocols? What can you actually start today and have a protocol around? So first, I just would like everyone to take a look at what are the differences. What would you see the difference between a standard practice versus an oral systemic practice? And Patti and I see this all the time. It's pretty clear to us the differences. What I want to highlight here is definitely the diagnosis, just what is subjective versus what is objectively. And we're going to talk in hand tonight about that. And so one of the big key components here for an oral systemic practice is that that mindset and that protocol really focuses around testing to find the cause, whether it's bacterial, looking at genetic risk, and inflammatory panels. And then really adopting that medical model of test, treat, test. How do we know we're at clinical endpoint? How well did our treatments work? And then you'll notice some differences in nutritional counseling. I think in a standard practice, most people would say hands down, you know, we talk about sugar, we talk about calories, but we don't really discuss too much about inflammation syndrome and having in-depth conversations about diet and what our patients can do. And then collaborating with physicians. We are so lucky to be part of the center and being able to have Dr. Golder there as part of the Heart Attack and Stroke Prevention Center of Central Ohio, that we'll be able to have that specialist right there at hand for our patients. But one of our protocols is actually creating those letters, getting to primary care, and it's really about co-management rather than just collaborating. And that becomes really important when we start talking about dental clearance. So when you ask what's actually happening in these practices, here's a great protocol of a practice that is really implementing and now executing the oral systemic practice model. If you take a look, it's a little bit more in depth about medical history. So we're looking at family history. We're looking at existing conditions. We're talking about wellness assessments and actually providing them right there chairside. So blood pressure, blood sugar, pH, able to get A1Cs, the LP-PLA2. We're really going to go in depth with bacterial load, genetics risk, and sleep studies. So it's really looking at what is the root cause of this person's infection, where is it coming from, and not just looking at signs and symptoms, but it's in addition to. So I want to make a point of that, really to hit that home, is that we're still looking for those signs and symptoms. We're still going to use that. We're not totally abandoning that. We're using that, but this is in addition to give us more information, and then to really test, treat, and test. You know, how effective are we? Where are they in their clinical endpoint? And then really bringing up some new trends that are happening, such as probiotic therapy, xylitol therapy, antioxidant therapy. There's a lot on plant-based diets and metabolic syndrome. And then two, how do we co-treat with the Heart Attack and Stroke Prevention Center? What does that look like? And how can we collaborate with our physicians? So if you ask me right away, oh my gosh, where can I start? There's some easy, simple things, and that's what we want to highlight here, from pH at the chair, blood pressure, blood sugar, saliva testing, blood testing, and just referring and getting the patient in the right hands for an inflammatory panel or a CINT scan. One of our favorites that you're going to hear from us tonight about is really about saliva testing. Since it's all about the hygienist, calling out to all you hygienists out there, we believe that saliva testing is probably the simplest and easiest way to take that first step into integrating into the oral systemic practice model. So to kind of sum up the difference, I think the biggest thing that we're looking for here is the difference between just looking at healthy teeth, which would make a healthy mouth, and moving into, hey, let's look at not only the teeth, but we're looking at the entire complexity of the mouth and how that impacts the body. So out of our 14 steps, we don't have time to go through all those steps. Patti and I would absolutely love to do that. But for time permitting, we're going to focus on a few of our key steps. And one of those is what we feel is the most valuable step in time management and delivery of quality of care. And that is morning huddle. It's probably the one of the most, I feel, underutilized and most overlooked steps there is. And so it's really kind of understanding that concept. And I love this quote by Abraham Lincoln. It says, if I had 9 hours to chop down a tree, I'd spend the first 6 sharpening my axe. And I think that's really important because it kind of relates to me if you've ever had to do a consult. You watch somebody work up the consult, you know, looking at x-rays, putting in the treatment plan, spending all this time on what they're going to talk about. Yet every single day in our chair, hour after hour, we're really having these mini consults with patients, but nobody's really prepared for that conversation. And so that's what, if you want to take away from your morning huddle, it's all about time management. What is that conversation? So you really have to know your patient. You have to know the case. You have to make sure that you've entered the correct services. What are you actually doing today? We call that the focus of the appointment. Am I even ready to have this appointment? And then number 3 is the key. What is the plan presentation, which we call the opportunity? What am I planned to present? What is the conversation that I'm ready to have with that patient? And there's a little key component to that because most people believe that they should be doing all the talking as the clinician. And we always say, you know, Danny, if you walk down the hallway of any operatories, you usually hear clinicians talking, and most people would agree with that. What we really want our clinicians doing is asking good questions, key questions to get their patients to talk to them. And that's kind of my second quote over here, is that the most important thing in communication is to hear what isn't being said. And so that is a huge takeaway, and just really taking some time to listen to our patient. But all this information you can see here on this EagleSoft routing slip, we actually put that in their patient memo so that it stays with the patient. And that becomes crucial because at morning huddle then, that's really all we need to use to be able to report on our patient. So here's a little protocol to help our hygienists, our team members kind of get on board at first so that they can get to that summary. And so what we're really looking for is the case, the health link, what's their long-term goal, which really has a lot to do, why would this patient say yes to treatment? I think we don't talk about that enough in dentistry, is really knowing their why. What would make them say yes or no to the case presentation? And then obviously the focus, what we're doing, and then the opportunity, whether it's existing treatment or new treatment. And so a morning huddle actually sounds a little bit more like this. I'm actually going to look over here to Miss Patti, and right, it would go very fast, but I would say, you know, I have Mr. Smith, age 22. His case is basic restorative. He's perio from 2012 sleep apnea case. His health link is high blood pressure, diabetes, and sleep. His long-term goal, and so this is the quotes of the patient, is to keep my teeth and make them look whiter. The products he's on is Sonicare, AO Gel, probiotics, and 20% whitening. His first test was August of 12. He was over threshold, but he cleared 11 of 12 and has been cleared since. His sleep study was completed, and he is in a dental client. My focus for today is a full perio chart with photos of 14 pending treatment, and the opportunity is isolated therapy, possibly retesting if active, and number 14, buildup in crown.
Hey, Danny, we're thinking maybe this is a good time for the poll question number 1.
I'm thinking, let's go ahead and poll the audience with a simple question, which is, how important is a morning huddle? And we'll just give everybody a chance to answer that. And the options are very important, somewhat important, not at all important, not sure how important. And I think really the point here is quality too. But I know you've already covered a lot about that. That was a very clear, concise, and no doubt effective use of time. You're really setting forth a protocol of a communication protocol. And I'm sure that you work in the, as you said, helping the patient identify their why, so that they're truly a partner in their treatment. And you know, it's not, we're just going to do this today. Well, no, last session we observed this and we agreed to do this, and based on the results of your latest test, we found this. And congratulations that, you know, you're no longer above threshold. You would explain what that means, of course. And you know, give them the good and the areas for improvement. All right, we are at 83% of those in attendance having voted. We know some of you are driving, so I think we're going to close out the poll now and share our results.
Yeah, and Danny, you know, we try to really make the morning huddle effective, so there's no breakfast club going on.
Right on. We had talked about that. If it just evolves to a bull session, that's not a productive use of time. Anyway, the results are in, and we're showing 97% get that the morning huddle is very important, and 3% are not sure. So let's continue. And thanks everyone for participating in the poll.
So tonight is all about the hygienist, and so we feel that it is of utmost importance to talk about the important role of the hygienist. And really, it comes down to one word, and that is screening. The major role of the hygienist, we feel, is to provide those screenings, whether it is on any level of dental screenings to even systemic screenings. And so since we're so compassionate about the oral-systemic link, and that's where our passion lies in really helping our colleagues learn and implement this, we really want to spread the news and get more clinicians screening systemically. And one of the first ways and easiest ways we feel to help that is to really think about your practice as being a patient-centered practice. Here's an example of what we call a focus sheet that makes it very easy to hand to your patient at the beginning and kind of really let them know that we're here. Obviously, it's an educational piece showing them everything that we're looking at, but it gives the patient, again, that opportunity to interact with you, start that conversation of many things that they would like to focus on today.
Yeah, you know, the last thing we want our patient to do is get into the car and be like, oh my gosh, I forgot to ask them about my sensitive tooth, or the fact that I wanted my teeth to be straighter, or I wanted my teeth to be lighter. I totally forgot. You know, we've all done that after a doctor's appointment. They're like, oh gosh, I forgot to ask the question.
And that is actually the last thing that we ever want to happen to one of our patients. You know, I've done that a million times myself as a pediatrician, or even written notes and forgot those of the questions I wanted to ask. So this is kind of that guide for our patient to trigger them to be able to have that really focused appointment that is centered around them. And then our screening here that we're going to use as an example of a great place to start in your practice if you're not testing yet or not really doing some of the what we call physical hands-on aspects, is that it just starts with a simple, different conversation. And we believe that conversation really can start happening in that medical history. So you're seeing an example here. And what I want you to pay attention to is that LP you're seeing, that's really the last physical. So we're asking them, when was your last physical? When was the last time they've seen primary care or one of their doctors? If they're diabetic in this case, you mark diabetes. We just don't say, okay, I used to do that 20 years ago. Just say, oh, he's a diabetic. Now we actually want to know, what is their A1C? Are they a controlled diabetic? How can we help them? And that conversation can start right here. And then as well as taking their blood pressure and putting that in and their glucose level. So I think this is a key aspect for those who just want to start. It's just having a different conversation, and this is right out of the gate with our patients. So again, that role of the hygienist is to screen, and I absolutely love this. This was back from October of 2011, but I'm going to read this to you guys here. It says, if you have an inflammatory condition, which the most popular example here is periodontal disease, it puts the individual at higher risk for a more serious systemic problem, whether it's heart problems, diabetes, or rheumatoid arthritis. As we take care of the mouth, not only do we save teeth, which is a very good objective, but we also protect our general health. And for us, that's really what the hygienist is doing is, can we reduce that burden? Can we reduce the inflammatory burden? And that's really what screening is all about. So I say to all you hygienists, let's get out there and start screening.
And, Dr. Doneen, back in February of 2015, wrote an article for RDH magazine, and I say it was a call to action. She was actually asking for a partnership with the dental hygienist to join the fight against the devastating effects of cardiovascular disease. And she said, as a medical dental team, optimal wellness can be achieved with each of our patients. So, we love Dr. Doneen, and she was actually giving us a huge call to action. We all need to take heed and work together with the medical community for better patient outcomes.
And a lot of people talk about this, how, a lot of patients, and I'm going to be a little biased here, but I think all of us who are married, and Danny can laugh at that, I don't know if your wife makes you go, but most of us make our husbands go to the doctor. And so, the females are usually leading this. And so many people see their dentist, twice a year, but don't see their doctor even once a year. So that just is really another reason for us to be paying attention to what's going on systemically to our patients.
Agreed.
So we have a lot to do in a hygiene appointment, and we call our step 4 is one of the key components of what we call the WOW exam. And this is a WOW experience. What we want our patients to do is to look at us and sit up at the end of the appointment and be like, wow, I have never been treated like this. I've never had an exam like this before. That's really our primary goal, is just to wow our patients and to have this amazing experience with them. And so if you go down this list here, there is a lot going on in that hour appointment. But we create these checklists as a quick reference guide for our hygienists so to keep them on track so that they can continually deliver that constant, effective care. So when we do things in a certain order, things become habit, things become really consistent, and then our quality of care really goes up.
And we say, sometimes you look at that, it looks like a lot to do, but you get that in your mind, it becomes a habit, like Laura said, then it's actually a time management skill. It actually helps you stay on time better just to know what you're going to do at every point of the appointment.
Especially when there's feedback with the patient and one task kind of flows logically from the last. It just becomes natural with practice, I'm sure.
Right, and we hear that from our clients sometimes, our client clinicians. They'll say, well, that's not the way I do it. That's not the way I like to do it. But when they get in the habit of everybody doing it the same way, it really gets more comfortable, and they are a little bit, more efficient and fast at it.
So keep that in mind as we go into step 7, which is our hygiene-led exam. We really try to create the consistency of our hygienists and our hygiene department really doing things in a certain order, and that's really for the flow of the rest of the team. Because any doctor could walk into a room here if a hygienist is doing all this, and really before their pro-fee, during their pro-fee, they could walk in and have what we call an anytime exam, and that is really crucial for time management. And so we use a lot of the best industry techniques. The first one that we really employ with our clinicians is all about self-diagnosis. The second is what we call the GPCS, and that's about your presentation. We love starting with something good. Everyone wants to be complimented, right, Danny? We always want to be complimented. And then,
like then
we go,
that's right.
That's right. And then we go into, with a photo, what's the problem, the consequence, and we feel the best solution. We also love one of the industry techniques, the feel, felt, sound. It's a great way to be able to relate to your patient. And all of this really just builds on the yes from the patient, getting that high level of case acceptance. But I know there are hygienists out there, and probably some dentists too, that, right, the number one complaint we hear is, we don't have time. You know, that's always the number one thing. There is no way I can add one more thing in my day. And, you know, being clinicians ourselves, we feel your pain. We are right there with you. And that's actually why we do these time studies. This is an actual time study done on myself and on a few clinicians that we work with. And why we create these is to show you that it is doable. Most of the time, I say many of us have never practiced, never done a time study on ourselves. You know, where are we spending that time? And so if you kind of look in the middle there under periodontal screening, you're going to see there's a levels of disease laminate, a whole perio chart, a case presentation sheet, saliva testing. There are key components in here that are really about time management so that we can have these quick efficiencies going on that really create a valuable appointment with our patient. So let's just talk about those 3 visual tools to increase case acceptance. For us, we're going to start with the basic ones, which is a laminate, a chart, and our case presentation sheet. These are really the cornerstone of the DHE method. All of our clinicians use these 3 visual tools in every aspect, and we even implement them and transition them over into the restorative side of our practices as we grow and coach them. So you can see here, here's an example of those 3 tools. We have a laminate here, progression of disease. We're going to talk about gingival height and perio charting, and then a great visual for our patients of non-surgical periodontal therapy. And that's the case sheet that you'll hear us call our case presentation. So the first one we're going to talk about of our 3 great tools is the amazing self-diagnosis tool. And even though we call it a laminate, this is all about self-diagnosis. I tease all the hygienists out there that you all know the progression of disease. You know, you don't need to be replaying that and saying that to yourself all day. It's really about the patient. So we say that this takes about 1 to 3 minutes to do. It really has an introduction to the progression of disease. We want to use pictures because we know as humans we learn best through visual and didactic. So we want them to actually hold it. We want them to see the pictures there as we go through, and then obviously sum up what they need to listen for. So we're really engaging the patient to be an active participant of our appointment. And this is what we call is all about self-diagnosis. We want the patient to tell us where they are on that laminate. And when a patient actually tells you they have a problem, your case is solved. You pretty much don't have to worry from there on out. And so then the second piece is our revolutionary way to chart. Many of us are unaware, but our charting systems, and Patti over here always blames the computers for this, but we really need to be putting in the gingival margin, and that's that GM line. If you just kind of look at that chart there, you can see MOB for mobility, PD for periodontal, for pocket depth. Then we have GM, gingival margin, and then the CAL, clinical attachment loss, and MGJ, mucogingival junction. So that CAL line needs to be accurate, and the only way to get an accurate reading is to actually put in gingival height. So we're not just talking about recession, we're actually talking where the tissue lies in relation to the CEJ.
So Danny, this is probably another good time for a poll question. Number 2.
It is indeed. Let us launch that. Our next question, folks, is do you chart gingival margin height? Do you chart gingival margin, that is height of the tissue, at all 6 sites? Let's go and see what our attendees have to say. People are responding more quickly. We're at about 2/3. Let's just give it another 10 seconds or so. A little bit more of a mixed bag on this one. Let's get up to 80%, folks. We're at 76. Okay, looks like we're stalling at 76, so I'm going to go ahead and close the poll and share the results, which are yes, 47%, no, 53%.
And that's actually a pretty good reflection, we feel like, because just at the beginning of the slide we were saying how 90% of people just go on signs and symptoms, you know, really understanding how to measure gingival height is like a whole new aspect for a lot of clinicians. So you're not alone out there if you're not doing this or you weren't aware of this, but this is just a great example of how you measure gingival height. You know, traditionally we know how to measure recession, which is, you know, the tooth on your right-hand side. But the tooth on your left-hand side, tooth number 8 there, a lot of people aren't taking into account that we have tissue on the enamel. What is that height of the tissue? And if we don't actually tell the computer to take that away, then that's actually going into our clinical attachment level or bone loss, which is inaccurate. And the interesting part is most dentists get this. You know, they've been trained to do that, especially, you know, really looking at cosmetics, seating a crown. They're very aware of that. But unfortunately, I feel like as hygienists, we were kind of shortchanged in this area. But once we take a look at pictures like this, we start to understand that concept fully. And so our chart needs to be accurate because really this is our legal diagnosis. And this is by the American Academy of Periodontology. If you feel a little lost or you weren't aware of this, we really recommend that you go to www.perio.org and go in there and look at the 1999 classifications and kind of understand how the charting is done. You know, we do teach it as well and really help our clinicians. And that's where the hands-on, one-on-one, just having that coaching, being able to get in the chair and look at each other and measure really becomes important for our clinicians. And so here's that classification system. Again, like I said, it was done in 1999, and you can see the 8 different classifications. And so the guidelines are pretty clear. I just kind of did a little snapshot here so that you could see those guidelines and understand that and how it's really a mind shift change. It used to be all about probing depths, and you can see how wide range those probe depths are, and that it's definitely more about the clinical attachment loss. So we're talking about, you know, I don't want to get into biological width or anything like that, but we're really talking about bone loss here. And so they make it pretty easy for us to make that diagnosis or what we call classification. So how do you sum that up? How do you make it easy? Well, they've made it pretty easy for us as far as gingivitis. That means no bone loss, or what they call in the presence of reduced periodontium, you know, just having bleeding. And we have slight to moderate, and that's bone loss or clinical attachment levels from that 1 to 4 millimeters, but it can be probe depth up to 6. And then we have the advanced, which is bone loss at 5 millimeters and up, and probe depths ranging typically from 6 and greater. So I think that's a great way to kind of get your mind around it, what we're really looking at as far as symptoms are changing, and then really going into the second factor of our bacterial burden. But first is, you know, can we make that clean, clear classification and that legal classification that we need in the patient chart? And then the diagnosis here kind of sum that up for you. And then let's look at treatment. Treatment, thank goodness, it has not changed. That is still based on our probe depth, our bleeding, our attachment loss, and the number of teeth involved. And so that ADA classification that you hear about, that's really for third-party classification and used on insurance forms. But as far as the AAP goes, we really need to write in the classification that they have set up for us to use. So the third visual tool that we want to talk about is our breakthrough and case acceptance. This is actually a key component of getting higher levels of case acceptance. Most of our clinicians average around 90 to 95 case acceptance in their perio departments, and we know that it's truly the sheet, using this visual sheet. A lot of clinicians, Danny, think that the sheet is for them, which at the beginning it is, especially if you've never had a case presentation sheet to use before. But it's really for the patient to follow along, to clearly understand, and to be involved in that kind of treatment planning and progress through their appointment of what needs to have happen. And so you should be seeing on there, we have some saliva testing, we have contributing risk factors, the oral systemic links, key components are risk, options, and outcomes, and then really highlight that we always have to answer the questions of time, pain, and money. Those are every patient's top 3 questions, and so you can see that that's on there as well. So here is our patient's treatment plan. As you can see, it's a little different from the other one that you saw. We have many different case presentation sheets because we really customize these for the practice, depending on the products they're using or the therapy methods that they want to integrate into their treatment. But what I love about this sheet is that you can see the classification right at the top. Then you can see understanding the cause. So we're looking for that root cause with saliva testing. Then we're placing them into what I call more of a traditional therapy, the scaling and root planing. And then it moves on to how are we going to support them periodontally, whether it's Boukheir, AO gel, probiotics. And then it allows us to make that medical link and those risk factors with the patient based on their medical history, and really opens that conversation up for that oral systemic connection. And then we always go through prognosis, risk, outcomes, as well as if the patient needs any type of referrals. So the case presentation is really done with these visual tools up. If you look at that picture there, even behind my right arm that you see, you'll see that we have a little flip chart, a CIMT, and we use these laminates in everything that we do, whether we're talking a saliva test, whether we're talking a CIMT or an inflammatory panel. And so it really allows the patient to be a part of their treatment plan and be a part of their care. So the visuals create huge value and that working relationship. We really want to be our patient's advocate and work with them. So the big concept that we want you to take away is that this provides you with consistent, effective communication, a great visual for the patient so they know what's going on, and of course, a wonderful legal documentation to be able to scan into their chart. So these 3 things will just boost your case acceptance, like we said, to over 90%. So what you're seeing on there is what we really want to move into next, and that is, okay, so we're increasing, our case acceptance. What about just increasing our periodontal treatment as a whole? And so this is where we're going to ask for that mind shift change. So we're going to switch from guessing about treatment and having just the same old treatment for every single patient to actually start testing and creating what we call personalized periodontal medicine. Can we personalize this treatment for our patient? But first I want you guys to understand what is the problem with just signs and symptoms. And so the first aspect is that it's just very subjective. We know that one hygienist can say that, it's 5 millimeters. Another hygienist can come in and say it's 6 millimeters, and I'll pull a dentist in, and gosh only knows, he could be 3 millimeters off and say it's 8 millimeters, and we've seen that happen. I think every colleague out there could chuckle a little bit if that has happened to them. So there's that very subjective point of view. And so that creates a lot of inaccuracies. How accurate is that going on as far as making that classification or diagnosis? And then it's very time consuming. It takes a long time to be able to document all these signs and symptoms. And so the consequences is that we're very inconsistent. So there's no real consistency going on. We say the old model really doesn't work. And we know that. Patients are continuing to lose teeth, and now we're seeing that they're losing their lives. We're really starting to see that in all the evidence-based dentistry literature and research that's coming out. And so let's talk about a solution, and that's really what's taking on this new paradigm shift in the new era of dentistry with the oral systemic connection. This is really about personalized periodontal medicine, providing the best care based on that person's individual needs. And we really can start now, which is just so exciting, to not only save teeth, but really have an impact on saving lives. And, that's that's our passion. We want to help people. We started by helping patients. We know that we can only see so many patients in a day, and that's really what drives us in our business with the DHE method, is helping our clinicians be able to implement this in their practice, because how many more lives that they can touch. So here's just a few of our favorite evidence-based research, and this is from the Journal of Stroke. This is their actual journal. And if you read this here, more than 500,000 participants, so that's a big study. It was shown that periodontal disease is such an important factor for stroke. More importantly, it showed that periodontal treatment reduced the risk for stroke. So that's huge. That's just giving, again, that documentation of the validity of what we do for our patients. Then in the circulation, which is from the American Heart Association back in March of 2013, really had a great study, and it tells us as many as 50% of heart attacks are being triggered by an oral pathogen. So if you haven't heard that before, you really need to go and pull this circulation article, because it's one of the best evidence-based dentistry documentation that we have, really making these connections. And I think it's very interesting that the oral bacteria were found in every thrombus. So that's an interesting aspect, as well as that 30% had live oral pathogens in the clot. And what I find so intriguing about research is that I don't think that we really even know what that means. So that's what's so cutting edge about some of the things that are going on and so exciting, is that we're really on this new frontier. And it's just amazing that we get to be a part, in this oral health and dental care, to really help people prevent heart attacks and stroke.
This research that comes from the medical journals and from the medical side of things are really good to share with any physicians that you're trying to bring on board, that you're trying to collaborate with in patient care, because they do respect their own journals, just like we respect our own journals. So to get some of these in your library to present to physicians that you want to collaborate with is a really good thing to do.
That's exactly what we do for our collaboration, Patti, just working with that, being able some letters, and then actually naming these pathogens. So here they are. They're actually named here, and again, take real notice on where these are coming from. So neurosurgery, psychiatry, just where these are coming out of, and so that really brings a lot of validity to our treatment and what we're doing. So how would you know if your patient even has those bacteria? You read these articles, you see them named from PG to AA, FN, TD, and so we love this. When it comes to periodontal disease, test, don't guess. And so we say, start guessing. Stop all this guessing. How do we know if the patient even has disease present? What is the severity? And really some deeper questions that we want to get into is, can the patient even fight this off? Can they heal? Can they recover? And so we really need to start looking at two huge aspects, and I get really excited about this. This is one of my deep passions, of just educating people on the pathogenic burden. So what is that bacterial burden? And then the second piece is the host. We've been talking about host response for many years, and now we really are diving deep into these genetic markers on their risk level. We actually can answer these questions.
Hey, Danny, good time for another poll question, number 3.
I agree. Let's find out about saliva testing, shall we? And the question is, does your practice perform patient saliva testing? To make sure we were clear about who we were testing. So the poll has been launched. We've already got over half attendees voting. 73%. Let's try to beat last poll. We'll give it just a few more seconds. All right, with 80% in, we've got 37% yes and 63% no.
Wow, well, that's still a great percentage of the people that are testing, and hopefully after tonight we can get more people moving towards that. And so this next slide that we really want to share with you will kind of open your eyes to that periodontal disease movement. You know, we're talking about a microbial challenge, so it starts there. That
Can I ask a quick
challenge
question before you jump into that? And if you're going to get to this, just tell me. But what do you think it is that's keeping practices from offering the salivary testing? Because I mean, a lack of awareness obviously is one, but I have to say that I recommend this to all my clients, and only a certain percentage of them ever really embrace it. Some of them try it and then they stop doing it, and they usually say lack of agreement or compliance, you know, on the part of the patient. So I just wonder if you're going to speak about it, great. If not, could you do that for a few seconds?
Absolutely. I think it goes back to mindset, because I think what you're talking about there is just an agreement. I think we have to understand how important that microbial challenge is, and, you know, we're looking at then that host response to that. And so, you know, I would love to poll the audience, actually, you know, what is holding them back? Because I think it's one of the simplest and easiest things to really implement in your practice. We'll talk about, you know, what's 30 seconds to actually be able to treat a patient better. Patti and I talk all the time about how this could really slow down refractories and prevent refractory disease by treating the patient right the first time. And I think we kind of have to get our minds around that. So I know in some practices, you know, people come to us that have dabbled in it, and then they're like, we just can't get it up and running. And a lot of times we find that they just don't have a set protocol. You know, people are just what I call pulling it out of the air. Again, I go back to morning huddle. You know, if you're ready, you're like, this is a peri patient, I want to test them, then you're ready to have that conversation. And that's going to be very easy. I think if you're not sure, and a lot of that is confidence, then I think it does. It kind of goes, you know, just like anything else, it goes back up on that shelf.
Right. Well, my experience is... Go ahead, I'm sorry.
That's what we find is that the people or clinicians that we coach, the more experience they get with it, the more confidence they get. You know, it's like, wow, I tested the last patient and it made such a difference, and they were really high burden with the really bad bacteria, and we treated them, you know, with antibiotics and whatever it needed, and, you know, it really worked well, so I'm going to do that again. So I think that experience is the best teacher.
Yep. I think that's, and on that's I think exactly right. And in my experience, which is anecdotal, I mean, I haven't done any quantitative studies on it, but the flip side of that is true too, that if you get a negative experience when you present it to a patient, and maybe more often than not they've chosen not to proceed, there's a tendency to not want to go there again, because none of us likes to fail or meet with rejection. But the reality is that most, if not all, learning is by doing, and you've got to just, you know, perfect your communication. And I think what happens is often people get something, they get excited about it, they have the zealotry of the recent convert, as I like to say, and then they believe that because they understand it, that their enthusiasm should be contagious and that the value of this should be self-evident, and the patient is looking at you like, you know, I'm not quite getting it. So I think it's all about communication. Ultimately, the patient has to ask for it. We can't be saying, and therefore I think you should do this. And I think most of our attendees already get that. I think the main takeaway is that it's not going to work perfectly the first time or the second time. But if you keep at it, and if you pay close attention, and in your huddles maybe discuss what worked and what didn't, what needed to be modified, that the learning curve is quite steep getting there.
Danny, you're absolutely right, and we find that this is one of the easiest things that our clinicians implement, and a lot of through that case presentation sheet, because communication is king. If we actually go through that, and really you're going through, you know, kind of standard treatment, you know, scaling, replaning your product, you know, your why of what you're going to do, but then you need to look at that patient, have that conversation, say, you know, let's find out what's causing this infection. And we can do that today. We can simply start with a saliva test. It takes 30 seconds, and we can find out what bacteria are actually causing your infection, and then specifically how to treat that infection, if you need an antibiotic or if you don't. And I think that's the important piece, is that visual. We actually pull an example chart, as you saw in my picture. There is a little laminate behind me, and that's of the test, so that patients can actually see the test. When they see that test and they see third party is actually saying, hey, I need treatment, I need an antibiotic, I need which one and for how long, patients are used to seeing that on their blood work, and I think the case acceptance rate goes way up. What we tend to find in most practices when we get hired or walked in is that, we're doing a lot of lip service, kind of like I'm doing right now. It's like we're just throwing up on the patient, telling them all that information. But it's hard for them to actually see that. So we need to use those visuals. We need to give the patient the proper education to make that decision. Let's do things right the first time. That's a great communication tool, is looking at a patient and saying, hey, I've been treating periodontal for 20 years. Let's do it right the first time out of the gate, rather than guessing. Do you need an antibiotic? Don't you? Should we put you on this product or shouldn't we? And I think we have to stop guessing. We really need to treat patients individually, and they get that. They will understand that. And so testing becomes a really easy yes for us.
And the visual aid is key, especially relating it to their experience in medicine, only going the extra step. People like to be tested and they like to improve. So you sort of show them visually, this is where you're at, great job here, and here's a couple of areas that we want to look at, and here's how we can address it. And then the other thing I think people need to remember is that silence is your friend. You don't have to be afraid. After you make a statement, give the patient an opportunity to process what you've shared and let them come up with the, well, yeah, what do you think we should do about that? Because when they ask, that's what we call a buying signal.
Absolutely. That's what you say. Most patients are saying yes because they're silent. That means yes.
Yes,
and most
silence is golden.
Yeah, I say clinicians are so afraid of silence. It's pretty funny to watch how uneasy we get. We think we have to fill that space instead of learning to be very comfortable with that quiet space. So thank you for that, Danny, because we completely agree with that. But
You're welcome. I'll be quiet now.
No, absolutely.
I'll be silent.
Understanding that microbial challenge, understanding that host inflammatory response, and then you can see there, by the time we see those clinical signs of disease, the process has already happened. I think that's what a lot of clinicians are missing. They're always like, oh, well, I'm going to wait and see what it looks like, or it doesn't look that bad, let's see what it looks like, next time. What are we waiting for? The signs and symptoms, the process has already started, and that's really with any inflammatory disease. And so we always ask, what other diseases, don't we see clinical signs till way later in the process?
Which just gives validity, Danny, to treating gingivitis, because we want to treat this disease earlier because it's so much easier to treat at that point, and we can't really gamble on whether it's going to actually progress to periodontal disease or not.
And so I want to give a shout out to AOSH because they've really created this OSH News Network. If you're feeling like on this webinar or the call like, wow, where's all this information? How do I get my hands on this? This really is the #1 place to go. And these two that I pulled from here are just close to our heart because of the Heart Attack and Stroke Prevention Center of Central Ohio, that we can see that certain pathogens really do contribute to, heart disease, arthrosclerotic development, and we're looking at that, as well as then being able to collaborate and work with our cardiologists on, helping people with their cholesterol. And I think that's huge. If you look at that 30% drop in LDL cholesterol, so, we're really working with our patients and showing them, too, by working with us, look what we can accomplish, look what we can do. And I think that's really important. And this site is just a wonderful resource for both clinicians to learn as well as for patients to understand. And so let's just talk about oral DNA labs real quickly here. They really have 3 main areas: the bacterial, genetic, and viral. We're really going to just focus on 2 tonight, the bacterial and that first genetic, and just kind of understand those, because I think we do have to start with the basics, which is understanding the bacterial risk, and then moving into that host response, which is the genetic. And so like we just talked about, it is so easy. This is a 30-second saline, swish, and spit. It doesn't get much easier than this. I tell clinicians all the time, this is the easiest 30 seconds of your entire appointment. It's so non-invasive. Patients are very accepting of it. And that lab report measures, that bacterial load. It's going to identify genetic risk. It can also identify viruses and yeast infections. And then what this is really doing for us, and this is important, it's really helping us guide in our treatment and then really monitoring what I call the clinical endpoint or that risk assessment. How risky are they for this disease to come back or for that infection to flare back up? And so that becomes huge when we talk about test, treat, test. And Danny, kind of going back to your other things, some people start testing and then leaving. I would say some of those clinicians are really missing that second piece, which is that post-test. What did their treatment do? What was the clinical outcome? And if we're not post-testing, then we're missing that. We're missing that second piece to let us know, hey, gosh, I need to be doing something different here, or wow, I'm right on target with this patient. And so looking at that bacterial burden, saliva testing really helps us treat periodontal disease. What is the best treatment? I think answering that question, do they need an antibiotic? I look at my patient all the time if they're questioning me about testing, and I'll say, I can't just look at you and say, oh, you need an antibiotic. You might and you might not, and that is the reason why we want to test. We want to treat you right. We want to treat you right the first time, and I don't want to guess on which antibiotic. I want to make sure I'm giving you the right antibiotic and for that right period of time. And so this is really all about better clinical outcomes. And that's really what our physicians are looking for as well. So we want better clinical outcomes, and so do they, and we really want to reduce these systemic risks that are connected to these pathogens. And so you kind of have to understand these two components of periodontal disease, the bacterial component, and be looking at that as well as the genetic component. And I'm not going to spend a whole lot of time on that. What I really want you to know is that, oral DNA provides both these components for us, and this is really the place to start to understand that. What bacterial component, this inflammatory disease, what specific microorganisms are actually affecting this patient, and what can I do about it? And then what is that host response? What is that genetic component? And, it is very complex, but we need to start learning and educating ourselves on this and how it really does affect our outcomes. So let's just take a look at My Perio Path. That's the one that we recommend people starting with. If you're not testing them, this is really the simplest way to start. And what you're doing is a 30-second swish and spit, and then you get this wonderful lab report back, and they're really measuring that bacterial profile for us. So, what is the risk at this point in time on the patient? So we can see out of those top 11 bacteria, do they even have them? And then what we call, how much the quantity, how much do they have? What is the burden on this patient? And that really can help us then make these treatment decisions. Do we need adjunctive antibiotics? Do we need local chemotherapeutics? What actually has to happen can really help us and establish those goals of therapy. And then that post-test I was talking about, this is a beautiful post-test, right? We'd all love to get this back, that obviously we made those great decisions for the patient, and patients love to see this. Patti and I can tell you many stories of our patients, as well as Dr. McCletchie, of them crying in the chair. They've been through surgery, they've been through, so many different types of treatments and procedures, and just to know that they're able to clear their infection and be in such a great, stable spot is pretty amazing for these patients. And so then we're going to move into the genetic piece, and that is the CELSIS one, and this is really looking at 8 gene markers associated with the increased risk and severity of not only periodontal disease, but diabetes and cardiovascular disease. So this is becoming really important for us as we are opening the Heart Attack and Stroke Prevention Center of Central Ohio, that, this is a direct correlation here. We really need to be looking at this for our patients and be monitoring their risk and getting them into the right hands of Dr. Golder, the cardiologist. And so these are just gene markers. This isn't going to change. This is the actual, DNA of this patient, and it's really basically letting us know the immune system is predicting this person's set point, or what we call baseline, for their inflammatory response. How are they going to respond? We talk about all the time, for that host, that host response. So you're going to have a key insight on that host response with this patient, and then how risky are they in the future. And so the easiest way to understand this is just that, you know, how can somebody fight this off? And their genetics really dictate that inflammatory burden on the patient, how their body's going to respond to that, whether it's against, you know, itself or non-self, how they actually mount their defenses and how their body goes to work towards that. And then this really pulls us into this whole oral systemic link, because we know that inflammation is the leading cause of all these diseases, and we are so interconnected with that. So this really advances just how they have here the efforts to understand the role of oral and systemic inflammation in disease and disease susceptibility. That's really what we're talking about here. What is this patient's, you know, susceptibility? What is their risk? How can we measure that? Because each person has this unique inflammatory risk. And that really then brings us to collaborating with, you know, our cardiologists or with just their primary care. And in our case, you know, we really then want to get them in the hands of our cardiologist for co-treatment with the Heart Attack and Stroke Prevention Center, so that they can actually run these inflammatory risk panels a little bit further, knowing that a patient does have an increased risk. And so in our office, that's actually what you get to see, is that we are practicing under this model of complete health dentistry. Dr. Barb McClatchy there, along with Dr. Eric Golzer, then is the cardiologist. So our patients are receiving this complete type of care, not only looking at what we call their teeth, we're looking at their mouth, we're looking at their body, and really having these specific conversations and creating that value for them that they really can't receive anywhere else. And so one point that we want to bring up is my genetics is just a great way that if you're like, oh my gosh, I don't know who to refer to, I don't know, you know, anyone nearby with who that I can use, or cardiologist isn't on board, we understand that. We know that it's different all across the country, and not everybody has this great collaboration going on. So there are some simple steps that you can even do right at your chair, and this is really how we started. We started looking at some blood markers that we did chairside. And so we were just looking at insulin resistance and inflammation, and you can do these two simple blood tests right there in your dental office through Heart Smart Screen, and that's my genetics. And so you can actually run a patient's A1C, which is measuring their blood sugar levels over a period of time, how that red blood cell interacts, and then their CRP, which is inflammation in the body. And these become really important because now you're speaking the language of, you know, the medical community, being able to just run these tests and getting them sent to the right hands, or, you know, really opening the eyes of their own physician who may be treating them, that they need to take a little look further, dive deeper into what is happening. And so as you can see here, here's just a great example of that from the Heart Smart Screen. And here's just an example of that blood card, how easy it is. It's about 4 or 5 drops of blood right on there. Again, this just takes minutes, and you send it in and you get those test results back. So huge value to your patient, especially somebody who maybe doesn't go to their primary care. You know, diabetes is insulin resistant. It's just on the rise. For us to be able to do this right at hand for our patients is a huge value, as well as just even doing a simple glucose test. You know, we've been doing this, just started this at the chair, and, you know, it's pretty eye-opening because there are so many pre-diabetics walking around that have no idea. It's just like blood pressure. So again, hygienists, I'm just really call to action, screen, screen, screen. It's just so valuable what information that we can provide for patients, and really you're creating these lifelong relationships with them because it's more than just their teeth. And so these type of tests really allow us to collaborate with the medical community. It brings a little validity. We're looking at the same things. We're kind of talking their language. And it also should be opening your eyes of, gosh, do I need an inflammatory panel? You know, what else does this patient need? And those questions should be going through your mind, as well as, wow, would I clear this patient for a dental clearance? And we recommend to all our clients that to really never give a dental clearance without a saliva test, without knowing that bacterial burden before they would go into surgery or have anything done. And patients really value that. Again, it's like something that they can give to their physician. Their physician can really see, or their surgeon, and really bring forward to what we're doing in their mouth and that whole oral systemic connection that's going on. So here's just an example of a letter. Again, we like to show some of our protocols. This is just an example of a letter that we help provide and help our teams get up to be able to really collaborate with physicians and discuss, maybe asking for an inflammatory risk panel or how they may co-treat. So we're lucky enough to have Dr. Eric Golder be able to do our inflammatory risk panels for us and be able to run that in co-treatment. And one of the labs here that I highlighted is the Cleveland Heart Lab, and then they can run these blood tests and really give the patient a better insight, and working with the cardiologist how to get, their inflammation down. How can we reduce that risk? And so these inflammatory panels become really important because, we're really working together at this point. We're networking with physicians. We need their help in our treatment, and they need our help in their treatment. And so it's a wonderful partnership to be able to work together and to do that. As well as in the office, our cardiologists and many of our primary cares across the country are now being able to provide the CIMT, that carotid intimamedial thickness screening, which is just so important when we talk about periodontal therapy. I don't know if many clinicians are aware, but treating periodontal disease really can reduce that CIMT, and that's one of the best ways that our physicians can monitor, a patient's risk. And again, I think it's a great visual for patients to be able to see that they are actually decreasing that. We're not only talking about,
That positive feedback is really gratifying, and I had a personal experience with that. I had my CIMT test at one of the early AOSH meetings. I think it was the one in, actually it was at a private physicians meeting in Boston in like 2012. And so it was, I'm pretty healthy, pretty fit, but I wasn't happy with the score. I was like, my veins or my arteries were like 2 years older than I am, according to their test. And I committed to mostly a nutrition regimen. And I got tested in 2 years later, and it had dropped significantly, and I felt good about that. It certainly motivated me to keep up the nutrition.
Absolutely. And again, this is just, and brings validity, I think, whether it's, just having, like you, talking about, whether it's diet, nutrition, collaborating, whether it's with their physician, what their physician, or cardiologist wants them to do. But again, to what we're even doing in reducing the risk and how important that is. And I think making those connections for the patient, again, I just go back to communication is king. Having that type of conversation with the patient, is really where it all starts.
Danny, since the CIMT picks up the earliest stage of arthrosclerosis, that gives us a chance to change our things that we need to change to not develop the full-blown disease.
Yeah, kind of the canary in the coal mine.
Absolutely. I just tell a funny story because we, to a lot of our presentations, if we have some of our colleagues online, we usually have the CIMT there done. And I always tease that sometimes after lunch, after people getting their CIMT done, it's awfully quiet at the lunch table because, we're guilty ourselves. I say, it's really open the eyes, just like you said, Danny, for yourself. And that's really where I start with a lot of hygienists is, screen yourself. Start with your own CIMT. Start with your own, inflammatory panel. Start with your own saliva test.
Yeah, that's a great point because, first of all, I tell people when in my telephone skills communications that, or any communication, if you really want to persuade, if you want to engage people emotionally, get them excited, tell a story, and preferably tell your story. Something that you experienced yourself that you believe in, and this also gets to leading by example. If you're going to preach health, I think it makes sense to be sure that you and your team are healthy and fit as well.
Absolutely, and that's why that's on here to build your referral base, because obviously you can send letters and do all that, but sometimes we make a joke about it, but it starts with you and maybe with your own primary care. So you can be using your own test to start your own referral base and networking right there. And so this is a whole mind shift that we're really just not cleaning teeth anymore. You know, stop guessing is the message and start testing. It really starts with you. Understand the bacterial burden, understand treatment, and we're going to kind of move into that. You know, what are our clinical goals? I think we kind of get removed from this of just treating, you know, patient after patient and not really evaluating and looking at what are our clinical goals? What are we trying to accomplish here? Are we actually reducing risk? You know, and are we actually screening all our patients? And so we're just going to talk about some of the latest treatment modalities to achieve great clinical endpoints. And three of our favorites are really probiotics, antioxidants, and xylitol because they are what we call like some of the new trends. But we're just going to kind of highlight new trends that are going on because it's just so amazing, all the wonderful things that are happening. And we want to open our clinicians' eyes that you don't have to be doing the same thing, that dental insanity. There are other things. So let's get out of the rut. Let's try some new things. And here's just some great examples of all the wonderful things that are happening out in this community. And so a couple of the products we would like to highlight or talk about are going to be on here, from Perisciences to Juice Plus to help with systemic, you know, inflammation, as well as our probiotics, xylitol therapy that I think is so underrated and not used enough in the entire dental practice. You know, oral DNA, you're hearing about how important it is to test and my genetics, but also just DNA appliance, talking about sleep apnea, ortho, and SmileMD, getting, you know, anesthesiologists to come to us and help us in our dental community is very important as well. So when we look at these bacterial links with genetic markers, these again are great visuals that we use with our patients that you see up there. We actually don't show these to the patient. Again, these are laminated. They're shared with the patient. We show them this once they get their test results back. They want to know, okay, what is the correlation here? You know, what's going on, especially if they have a family history and what's happening. And then, you know, we ask all the time, is your treatment personalized? And I think we really need to take a deep breath here and really be honest. You know, don't coddle yourself. Is your treatment really personalized for each patient? And so we create these sheets for our patients as well as for our clinicians to really talk about personalized treatment. We're just not putting everybody, you know, on Perisciences and everybody on a Lora Pro probiotics. We're only putting patients who need them on them. And testing is really crucial for that. So this is really about personalized treatment. And this means way better outcomes for that patient. And so your role is to screen, is to manage, and is to reduce risk. Then we need to be asking ourselves these questions. And I think that first question that I want to hit home with the hygienist, because it is all about hygienists, you know, just like 90% are just going on signs and symptoms, I would say then 90% don't realize that we have scaling and root planing resistant bacteria. So that would be a great question at some point to find out. I would love to know the statistic on that because just about every practice, when you say, Patti, that we walk into, they are completely unaware that we have scaling root planing resistant bacteria.
Well, unlike what we've been told for many years that we killed so much more bacteria with our ultrasonics. So we, you know, started using ultrasonics more, thinking we were killing bacteria when we are really not being able to kill the worst ones.
And then we've really dived deep with our clinicians on treatment. You know, we teach 5-tip therapy, but there's so much out there that we love to introduce. You know, whatever our hygienists are excited about or want to learn more about, then we're going to help them create the protocols around that. I think number 2 there, arrestin. I hear a lot of people, oh, just put arrestin in there, just put atrodox in there. And so we really educate our hygienists. You know, you can Google that on YouTube, that arrestin is actually for red zone bacteria. So again, why am I going to throw arrestin in a patient if they don't have any red zone bacteria? You know, I might as well just shoot it on the floor. And I think a lot of hygienists, you know, I've said that before in my seminars, and they've like, oh my gosh, there's been so many times I'm like, did I drop it on the floor? Did I shoot it down there? You know, did I miss, not get it in the pocket because they didn't get a good response? So again, we're guessing that these things would actually work for our patients. We don't have to guess. The information is right here. And that's even true of our probiotics. Lora Pro is just one of my great standing products, But again, I want it specifically for the patient. So I need to know if it's going to work for that patient. I've got to test and see which bacteria strains are there. Is this product going to work? And there's other great products. I know Dr. Mark Hannon was on here. He's just, if you've never heard him, please go and listen to him. But he just gives us so much great information on replacing bacteria, that bacterial load with good bacteria. And so he talks a lot about photosan and prolaxan and doing that, and that's another great way too. As well as xylitol, you know, we're looking at pH, we're looking at PG, we talk about acidity, periosciences as well for healing and pH, and then Juice Plus is just such a key component. I watch so many people go through treatment and then we're really not, you know, asking them, how are we supporting them systemically? We've done all this testing and people who really are what we call a high genetic risk, how are we going to support them? And so we have these treatments, you know, basically this is a traditional model with new technology, and that's what we're implementing. So we're just going to show a little bit about pH. Some people have never done that in their practice. Again, it's simple, chair side, but it's all about root causes. I think it's interesting, a lot of people don't know how to get a cavity, yet they are in the dental field. It is all about, again, bacterial burden, that bacterial load. And so how can we treat this? And I love this little thing because, you know, some people feel like Charlie Brown, like, good grief, you know, their head hurts. They haven't listened to this evidence-based dentistry before of changing, I call, etiologies and what's actually going on. Your brain may hurt. But we hope we open your eyes to some new things and understanding really how xylitol works compared to fluoride. And then here's just a great example of our restorative laminate. We take all these principles and we really apply them over to the restorative side. So again, you saw how we test, you know, in perio. Well, you just saw how we can test for decay. And then we get our patients to self-diagnose with that restorative laminate, which is just so key again when they say, oh my gosh, I'm here, this is what's wrong, you know, how can you help me?
We found that restorative laminate helps so much because it's so unbelievable really how patients don't understand the progression of infection in a tooth. Just like they don't understand the progression of periodontal disease. And so this laminate was actually created by one of our clients. And it just really has been very effective with patient education on case acceptance.
And so when you ask us what we do, this is just a prime example. We just create consistent execution through our protocols. We help write those protocols. We teach hands-on. We go through basic outlines, get everyone performing. I do want to highlight for my hygienists, yes, we do tongue prophies. We absolutely love them and provide them for our patients and teach those if you've never done one. It's a lot of fun and a great experience for your patient. But again, these are just these great consistent protocols that we want to deliver all the way through when the doctor comes in for that hygiene-led exam. We're going to just lead the doctor right through that appointment. I always tease, this isn't for break time, this isn't potty time, go get a drink, leave that sorry. No, this is the show. You're on, and we really need to walk that doctor through all that information.
And it is certainly not a time for the doctor to go on a scavenger hunt. We've been with the patient for 50 minutes. We know what we want to have them address, and we need to help them all we can.
And so again, just having that protocol in place and really understanding how that goes makes a seamless, really high level of case acceptance for our patients. We keep it simple and understandable, and patients want that, you know, when we can really discuss their why and make it personal about them. And so this is really just understanding the basics, understanding clinical endpoint, getting that mind shift, stop guessing, start testing, start really creating personalized periodontal treatment and personalized treatment throughout your practice as well, even on the restorative side and throughout. And so we really ask you, what's your why? You know, why do you do what you do? Why are you on the call tonight? We hope to stir that passion in a few of our colleagues out there, you know, to take that step, take that leap of faith, go ahead and start testing. And start with yourself, because in your career you will save someone's life, and it might be your own or someone you love. And so we want to make a difference in dentistry. We ask you to join us in doing that and spreading the news. And what we have for you guys tonight is a little offer to complete a questionnaire with our company. I know Danny will be sending that out, but it's easy to get started. All attendees will be sent a link with the Practice Builder questionnaire, and all you have to do is return that by August 31st, and you'll receive a 10% discount on our program. So we thank you for joining us, and Danny, we're going to turn it back over to you.
Thank you very much, Patti and Lora. That was excellent, and I am grateful, and I'm sure our attendees are grateful as well, for a really generous offer to get some one-on-one time with you. And I know, having worked with you, that you are very passionate about what you do, and the consummate professionals. I think that today was a very powerful insight and taste of what you offer. So thank you again for that. We had a very engaged audience this evening, not surprisingly. Let me dive into questions because we have a lot of them, and I can apologize in advance to several people that we won't get to all of your questions, but we will send them to our presenters, and I'm sure they'll follow up with you offline. First question, how do you ensure morning huddles do not devolve into breakfast clubs?
Well, Danny, that's a real good one because our teams do tend to want to do that. And so the main thing we do is we assign someone to be accountable for keeping that moving. And once our clinicians know that they're supposed to, just report the summary, and someone on the team is getting them on ready to go, and they actually just report what they're supposed to report, it can move really quickly. We have teams of 30 people, and they can get through a morning huddle in about 20 minutes. So just keep them on pace. It's good.
Yep,
and
work
have
the
fun.
plan. Yeah, I'd have a good time and get excited, focused. That lessens stress, and then you get more done in less time. Next question. Do you present therapy before the salivary test results come back? And I guess implicit in that question is how long does it take to get the results?
Yeah, so that's a great question. We do. That's why we use the case sheet, because we're still going to propose what we call, standard treatment. They're still going to go through scaling and root planing. So you're actually presenting that case sheet before you get that test back. And then the test usually takes, depending if you're doing 1 or 2 tests or however many tests that you're doing, typically somewhere about 2 weeks. We say anywhere between 7 to 10 days if it's just the bacterial burden. That my periopath usually comes back a little faster than the genetic. But we usually give our patient about 2 weeks, and we go ahead and we immediately schedule them out for 2 weeks and tell them that we're going to go over their test that day, and that if they need antibiotics, they'll be getting it that day, and then we will be customizing their program, based on their test results.
Excellent. Do you think it's common knowledge that heart attack and stroke are preventable? I think a lot of people don't know this and assume it is synonymous with, quote, dying from natural causes, end quote.
Well, thanks to all the people at AOSH that have been educating us for every year. We know that it certainly is, we are capable of reversing heart disease and stroke and diabetes and all that. And so, I don't think that we thought that it would be possible, but now that we're learning the root causes, we can definitely address those early and absolutely prevent the events from happening.
Right, and the more people hear about it from various credible sources, the more it's going to become common knowledge.
Absolutely. We hope we'll see everybody at AOSH next week.
That's right. That's right. What is a reasonable time frame for the hygiene team to embrace this new paradigm?
My number one answer for that, Danny, if you're listening out there, is how good is your team? And that is the absolute truth. We have hygienists who are just ready to jump in, and they can really get this program up and running in a matter of, a few months, to where we have some other teams that it can take them a whole year. And that's typically what we ask this to go through our full program, that, they kind of embrace it and give their team that year to really learn and implement. We have 3 phases. We have the implementation phase, we have the execution phase, and then the mastery phase. And it's really important to understand those phases and how we work through them hands-on, one-on-one with the clinician.
Very good. When do you recommend antibiotics?
You know, what's really been interesting to me as a long-time clinician is that when we started to really communicate about the levels of disease and the fact that periodontal disease is actually an infection, you know, I've had a lot of patients who would just be like, well, good, if I have an infection, shouldn't they give me an antibiotic? And, you know, the answer for so many years was, well, you know, we don't do that because we don't really know what's causing your infection. We don't know which antibiotic to use. So now it's such great news that, you know what, you may indeed need systemic antibiotics. And if you do, we'll know that from your test.
That's right. Do you recommend nutritional supplements? That was asked a little early. I don't know, you know, you talked a little bit about it, and I know that Juice Plus was one of the items on your on one of your slides. But yeah, could you respond to that more fully?
Sure, Dan. What was the question, Danny?
Do you recommend nutritional supplements?
You know, I'm actually a cancer survivor, so a little tidbit on that personally. I just want to hit on two things. One is I'm not a nutritional supplement supporter as far as isolated vitamins. There's a nurses study that was published very highly against that. And in cases like me, I'm a high-risk patient. If you flip back through our case study, you will actually see my cells with sweat on there. And I have a very high risk. So, you know, for me to take an isolated vitamin is not a good thing. It has shown that it can actually turn my cancer genes on. Whereas maybe somebody who doesn't have that risk, again, why that Celsius one would be so important, because that's my inflammatory response, you know, they may be perfectly fine taking an isolated vitamin. But the reason why we support Juice Plus is that it is not an isolated vitamin. It is not considered a supplement. It is actually food. It is, by the FDA, it is declared as food. It's freeze-dried food in a capsule, and it is 100% bioavailable through our bloodstream. So for cancer patients or people who are high risk like me, you know, that's very important for us, that our cells are actually receiving that on a cellular level. We're not dependent on breaking that down or that becoming toxic in our bodies. So that is a great question. A lot of people aren't aware of that.
Well, we've got several more questions, but we're going to finish with this one because there were 3 variants asked, which basically gets down to how are we paid for these tests? You know, do we offer it free? Is it fee for service? Is there third-party reimbursement? And if so, is it reimbursable by dental, medical? That was the question, suite of questions.
Yeah, it's a loaded question on there, Rich. You know, I really want to say that Oral DNA, Access Genetics, they're just wonderful, really walking through your practice, you know, especially in your area, what the going rate is, how to do that. They provide all the codes. But kind of a general overview, I always like to try to answer everybody's question the best to my ability, but they really are the resource for you to go to. But we do, you know, charge our patients. I would say the going rate is anywhere between $150 to $160. Obviously, if you're a periodontal office or a specialist or a cardiologist, you could be offering that at a higher rate. But I would say our average clients are somewhere between $150 and $160 for that periopath test. And if you ran 2 tests, we offer that somewhere around $280. And that is, you know, their fee. As far as for you, to just touch on the periopath is where we recommend starting. That usually costs you somewhere around $99. And then you have some shipping on that depending how many tests you ship at a time. Obviously, group shipping and doing multiple tests helps you with that price. So, you know, I'm very honest with doctors. This isn't a huge moneymaker. You know, this really is patient-centered. This really is about doing the right thing for your patients. But I will say for 30 seconds, you charge $150 or $160 and, right, you know, time. Talk about efficiencies and money, profitability. Yeah, it takes her 30 seconds to swish and spit, and you make, you know, on that whatever, depending on what you charge. So it definitely, you know, is more of a practice builder. Patients walk out saying, wow, that's what my dentist provided for me. Wow, look at my dentist sent this to my physician. Or, you know, my A1C, my blood sugar levels are better. We have patients every day come in telling us, you know, I'm taking less blood pressure medication, or I'm not even on my blood pressure medication. So to me, that's priceless, because that's where you get your referrals, that's where you get lifetime patients. So it's more than, to me, just that initial return. And then as far as coding, it really, to me, is a little bit all over the board. From, we just tell our patients it's not covered at all. We just take that right out of there, right out of the equation, and just tell them right up front, it's $150 to do the test. We'll send it out just like you would your lab work, and I'll be back in a week, and we'll go over that with you.
I'm really glad you said all that, because this is priceless, and it's a practice differentiator. We actually recommend that you read the patient. You be firm in policy but flexible in implementation. And if a patient resists on the first test, it's all in how it's presented. Principles of persuasion are that you offer a gift that's unexpected and personalized. And the hygienist can say, we typically receive $160 or whatever it is for this, but I know that we're so passionate about making sure that you get tested that if you're uncomfortable paying for it, we'll pay for it for you. Now, you're not committing to doing it every time. And obviously, part of the value in this is getting a baseline, and then you will test subsequently. So as an option, you may want to consider presenting that way, especially at the beginning when you may be uncomfortable asking for it. Get those success stories under your belt. It's worth paying for if you want to look at it that way, at least in my opinion.
Danny, we also, want to talk about how long-term these patients will have better results. We've been testing for over 2 years, and that's what we find is that, we know that long-term they are going to be healthier and have less recurrence of their infection and active stage for a lot longer in between. And I don't know how many tests oral DNA is done, but they don't really, I don't think, tell us exactly how long the patient would be healthier, but we're finding in our own practices that they are staying healthy longer.
Right. All the more reason to get people tested, whether they pay for it or not. And I think on that note, we're going to wrap things up. I want to thank again our presenters very much, and I want to thank all of you for staying on a few extra minutes. In a few days, you'll receive an email with the questionnaire, promise questionnaire from Patti and Lora, as well as instructions on how to apply to receive your CE credit. And I now want to invite you to mark your calendars for our next exciting webcast, which is scheduled for Tuesday, September 20th at 6:30 p.m. Central Time, when my very special guest will be Practice Perfection alumnus and my good friend Dr. Peter Evans, who will deliver the New Patient Grid, how to have new patients accept your best care and keep them for a lifetime. I want to thank also the Dental Herb Company for making Dr. Evans' presentation possible. Until then, this is Danny Bobrow, thanking again Patti and Lora, and thanking all of you for your continued commitment to practice perfection. Goodbye, everybody.